Hi, my name is Tade Jarutimi, a senior lecturer in the Department of Obstetrics, Gynecology and Perinatology, Obafemi Awolowo University, Ile-Ife. I welcome you to this session on natural family planning methods and barrier methods. It's expected at the end of this session that you will be able to comfortably discuss about natural family planning methods and barrier methods, knowing their mechanism of actions and the pros and cons associated with the use of these methods. We'll start off with natural family planning. What is natural family planning? It is the use of signs, symptoms, and cycle data to determine when ovulation occurs. Abstinence from intercourse during the at-risk fertile days is required. And for a fertility awareness method to qualify as a natural family planning method, they must be used with periodic abstinence rather than in combination with an artificial contraceptive method. With perfect use, modern natural family planning methods can be as effective in preventing pregnancy as hormonal contraceptives. We have 5 modern natural family planning methods. The first is basal body temperature charting, which identifies the luteal phase of the menstrual cycle by post-ovulatory increase in basal body temperature. All the other days outside these days are considered fertile days. The calendar calculation method predicts the fertile period by menstrual dating. Cervical mucus monitoring identifies the beginning and end of the fertile period using observation of cervical secretions. The lactational amenorrhea method maximizes suppression of ovulation during breastfeeding. The effectiveness of this method is limited to the 6 months postpartum period. And last but not the least, the symptothermal method, which is based on cervical mucus monitoring, calendar calculations, or basal body temperature charting monitoring. We will go into details about each of these methods as we go on. So what's the mechanism of action? Identification of the fertile period is the central focus of most natural family planning methods. In the periovulatory period, there is secretion of estradiol from the maturing follicles of the ovaries, which will stimulate the secretion of thin, stretchy, watery mucus in the cervical canal. The function of this is to facilitate sperm entry. Sperm entry is inhibited after ovulation by the secretion of thick, sticky cervical mucus, which is stimulated by increasing progesterone levels after ovulation has already occurred. Sperm can remain viable in the upper reproductive tract for up to 5 days, while the ovum will remain viable for fertilization up to 24 hours after ovulation. The usual viability periods of sperm and ovum combined together will generate an average 6-day fertile period. So when a couple is practicing natural family planning, they are supposed to abstain from intercourse during this 6-day fertile period of the cycle. Let's go into details about each of the specific methods. Using calendar calculations, the beginning of the fertile period is calculated by subtracting 18 days from the shortest of the previous 6 or 12 cycles. For women who have irregular menstrual cycle, this may not be very practicable. But if the menstrual cycle is regular, so they can pick the shortest of the previous 6 to 12 cycles that they've experienced and subtract 18 days from that. That will give them the beginning of the fertile period. While the end of the fertile period is calculated by subtracting 11 days from the longest cycle. So for instance, if a woman has a cycle length that varies from, let's say, 26 to 30 days, to calculate the beginning of her fertile period, she will subtract 18 days from 26, which is the shortest cycle for her. So, and to calculate the end of her fertile period, she will subtract 11 days from 30 days, which is her longest cycle. For women with perfectly consistent 28-day cycle, the rhythm method will predict an 8-day fertile period from days 10 through 17 for them. Variations in cycle length would increase the length of the predicted fertile period. The standard days method is a modification of the calendar or rhythm method. Is a simplified calendar method that assumes a cycle length of 26 to 32 days and sets a 12-day fertile period from days 8 through 19. Basal body temperature charting method. The woman would observe an increase of at least 0.4 degrees Fahrenheit or 0.2 degrees centigrade above the baseline temperature recorded early in the morning at the same time each day, and that will indicate that ovulation has already occurred. So this increase will be monitored over 3 consecutive days, at which point the fertile period is considered over, and then the woman is now safe from getting pregnant. The drawback of this is that the basal body temperature charting does not identify the beginning of the fertile period. Therefore, its use is limited. And as a result of this, the basal body temperature charting is typically used in combination with other methods. The cervical mucus monitoring method, popularly called the Billings ovulation method, and also a modification of it, which is the Crichton model and 2-day method. They are all different systems for observing cervical secretions, and they can also be used as markers of fertility for those who are hoping to conceive. The Crichton model is a standardized modification of the Billings ovulation method that is taught and personalized for couples over multiple sessions. The 2-day method is an attempt to simplify this method. It reduces the interpretation of cervical secretions to 2 questions for the woman. The first question is, did I note secretions today? And second, did I note secretions yesterday? If the woman's answer to both questions is yes, to either of the questions or both of them, then she's considered fertile for that period. So this is a simpler way of monitoring the cervical mucus and using it to prevent pregnancy. The symptothermal method combines calendar calculations with basal body temperature charting and cervical mucus monitoring. So it's a combination of the previous methods that we have discussed. Cervical secretions are the foundation of the symptothermal method, while the other techniques will provide a double check just to make it more effective. Women may use other signs, for instance, the consistency and position of the cervix, or symptoms such as breast tenderness, ovulatory pain, to aid in the identification of the fertile period. The Marquette model combines the use of an electronic hormonal fertility monitor to detect metabolites of estrogen and luteinizing hormone in the urine, with observation of cervical secretions or basal body temperature charting to identify the fertile period. All this is done in an attempt to make the method more effective. Then we have the lactational amenorrhea method. In the lactational amenorrhea method, practiced by women who are exclusively breastfeeding, ovulation does not occur and there are no fertile days, because it's believed that as long as the woman is exclusively breastfeeding, there will be suppression of ovulation. So its use is limited to women who are within the first 6 months postpartum, and it applies only if menstruation has not resumed. So in other words, if the woman is still within the first 6 months postpartum and she has resumed menstruation, then the method is no longer considered safe for her. When these conditions are met, lactational amenorrhea has been shown to be 92 to 100% effective at preventing pregnancy. There is a new invention called the Natural Cycle app. It's a fertility control method that was recently approved by the FDA. It's a little bit controversial because it's a mobile phone app to facilitate fertility awareness. The Natural Cycles app helps women to track their body temperature and menstrual cycle, and it advises them on when they should abstain from sexual intercourse or use other contraceptives such as condoms on the days that they are most fertile. So if they are using it in combination with contraceptives, it will not really qualify as natural family planning. So, but if they abstain from intercourse during that period, then the Natural Cycle app can qualify as natural family planning method. So we want to discuss the effectiveness of modern natural family planning methods. The effectiveness is measured for both perfect and typical use. Perfect use failures represent failure of the method itself, a failure that is inherent in the method itself when it's used as prescribed or as expected. So whereas failures occurring during typical use include incorrect or inconsistent use of the method. The reported failure rates for modern natural family methods range from less than 1 to 5% for perfect use, which is almost at par with some hormonal contraceptives. So, and 2 to 25% for typical use. The few randomized control trials of natural family planning methods have been limited by poor recruitment and high dropout rates, because for couples to practice it, they need to be highly motivated in order to be consistent. What are the benefits of natural family planning? It provides an enhanced understanding of the reproductive process that empowers couples to manage their reproductive lives without medical intervention. And also by routinely observing biologic markers, for example, temperature, checking their breast and all that, women may detect medical problems and bring them earlier than otherwise to the attention of their physicians. All natural family planning methods encourage couples to engage in a shared discussion about sexual activity and reproduction, and this can also pave the way for gender equity in family planning. And lastly, they do not require pharmaceutical or procedural intervention, and they have no medical adverse effects. As much as these benefits seem attractive, natural family planning methods also have their limitations. Part of the limitation is that compliance with periodic abstinence may be difficult for some couples, and this is evidenced by the relatively high failure rates associated with typical use of the methods. The periodic abstinence can also lead to marital disharmony. Also, all natural family planning methods can to varying degrees overestimate the fertile period and require longer periods of abstinence than might otherwise be needed for the couple. Also, illness, disrupted sleep, and the use of certain medications can alter or interfere with the observation and interpretation of some of these biological markers that are used in monitoring natural family planning methods. So we move on to barrier methods of contraception. Barrier methods of contraception entails physical barriers such as the male condom, the female condom, the diaphragm, the cervical cap, and the sponge, as well as chemical barriers in the form of jelly, foam, or films containing spermicides. Physical and chemical barriers are often used in conjunction to prevent the passage of sperm. What barrier methods do is to prevent the sperm and the ovum from meeting. So in many cases, they also provide protection from sexually transmitted diseases. And another advantage is that they can be used intermittently and do not have systemic side effects. The first of them that we'll look at is the male condom. The male condom has become an important public health tool because it can protect against the human immunodeficiency virus. It's traditionally made of latex and usually pre-lubricated, and may be lubricated with just ordinary lubricants or may also contain spermicides. There are newer forms of male condoms that are currently being made from synthetic non-latex materials, such as polyurethane. Example of that is Avanti. And another material is styrene ethylene butylene styrene, also called Tactilon. So this allows for a thinner membrane that is also not easily breakable. So perfect use of condoms provides a 3% failure rate in the first year. Typical use failure rates for the condom are closer to 14%. The pros associated with the use of male condoms include the fact that it protects against sexually transmitted diseases, including HIV. Condoms also prevent the sequelae of sexually transmitted diseases, including infertility, hepatitis, cervical dysplasia, and pelvic inflammatory disease. They are relatively cheap, easily obtainable, and easy to use. Disadvantages associated with condom use include factors that are inherent to other coitus-dependent methods, such as inconsistent use, which may be a particular problem with male-controlled methods. For the father is not under the control of the female. And some men also complain about decreased sensitivity with condom use. So we move on to the female condom. The female condom is made of polyurethane material, trade name Femdom or Femshield. It's 78 millimeters wide and 170 millimeters long with a silicone-based non-spermicidal lubricant on the inside. It has an inner and outer ring. The outer ring provides some protection because part of it sits on the perineum. So it provides protection for the perineum from sexually transmitted diseases. It can be placed up to 8 hours before intercourse, so the woman has some degree of control. She doesn't need to wait until it's time to have intercourse before placing it. It's usable only once and can be used with fast soluble jelly. And please note that the female condom is not to be used simultaneously with the male condom. Using them together simultaneously may cause adherence between the two condoms and it can lead to slippage. The pros associated with the female condom is that it's a female-controlled method of contraception, so it's under the control of the woman. It also prevents against sexually transmitted diseases. It has a longer shelf life, being made from polyurethane, and it causes fewer allergic reactions because some women can be allergic to latex. Two issues limit the widespread use of the female condom. Number one is acceptability. Most people are yet to come to terms with using female condom, and most of the time there's disapproval on the part of the male partner, and it's also costly for many family planning programs, unlike the male condom, which is cheaper. Another barrier method of contraception is diaphragm. This is the first available female-controlled method of contraception. The diaphragm is a rubber cup that fits into the vagina and covers the cervix. It comes in a number of styles for different vaginal tones. There is a flat spring rim that is designed to fit women with high vaginal tone. There is a coil spring rim for women with average tone of the vaginal muscles, and there is the arcing spring for lax vaginal tone. Diaphragms also come in sizes ranging from 50 to 105 millimeters although most women will use sizes ranging from 65 to 80 millimeters. The pros associated with the diaphragm is that it's under the control of the female, and there is no major morbidity associated with its use. There are cons, however, in that it increases the risk of urinary tract infection. An explanation for this may be the pressure on the urethra and also incomplete bladder emptying due to the anatomical relationship between where it's placed and the bladder neck. And rarely it may cause toxic shock syndrome if it's left in place for too long. And also because it's made of latex, those that have allergy to latex material may develop reactions to it. Cervical cap is designed to fit the cervix. It's a latex cap that stays in place by suction and anatomic placement. Unlike the diaphragm, the cervical cap can be left in place for up to 48 hours. It does not need additional spermicide for repeated acts of intercourse. So for the cervical cap, it doesn't need to be changed after every episode of intercourse. It can be left in situ for 48 hours. The cons associated with it includes the increased risk of urinary tract infection, which is similar to that of the diaphragm. Also increased risk of bacterial vaginosis and candidiasis, possibly because it's left in place for longer than the diaphragm. So there are two new devices that are modifications of the cervical cap made from silicone, Leah's Shield and FemCap. This generates fewer allergic reactions because they are made with silicone instead of latex. Another method is the vaginal sponge. The vaginal sponge does not require a prescription or fitting, and it provides 24 hours of protection from pregnancy. It can be used for multiple acts of coitus over this period. There has been concern raised regarding possible erosion of the cervical vaginal epithelium owing to prolonged contact with the spermicide used to impregnate the sponge, which is nonoxynol 9. This erosion may lead to increased transmission of HIV and increased rates of seroconversion in women with HIV-infected sexual partners. The protected sponge is a newer invention of the vaginal sponge. It's made from polyurethane foam. It's a non-prescription contraceptive. It contains 3 spermicides that also exhibit in vitro antiviral activity and thus may help to prevent the transmission of sexually transmitted diseases. So we move on to spermicides. Spermicides consist of a spermicidal agent and a carrier for it or a base. Although numerous preparations exist, only nonoxynol 9 and octoxynol 9 are FDA approved. The active ingredient in spermicides is a surfactant that destroys sperm cell membrane by increasing the membrane's permeability. The carrier for it may be a gel, foam, cream, film, suppository, or tablets. Gels, creams, and foams are most often used with diaphragms and cervical caps, but can also be used alone. These carriers contain 50 to 150 milligrams of spermicide. Suppositories can contain between 50 to 125 milligrams of spermicide, and they can be used either in conjunction with condoms or alone. In conclusion, despite the challenges, the cons that we have discussed, natural family planning methods are a viable and effective family planning option for motivated patients and may be the ideal option for some. For some, it may be the only option. Barrier methods work as contraceptives without systemic side effects, and this makes them particularly appropriate for women with medical conditions that prevent the use of hormonal contraception. Their continued importance is evidenced by the ongoing research to develop and improve these non-hormonal methods of family planning. These are some of my references. Thank you for listening.